It's really important to understand what's going on in the NHS in 2021. We've had cuts, privatisation, rationing, shortages and structural change, all during a pandemic which is underfunded and chaotic. I'm speaking from the standpoint of trade unionists, of socialists, so I'm saying that we support the 15% pay rise for NHS workers. And we will continue to defend the NHS now more than ever. But this is a complex situation that needs some detailed understanding. It's not well covered in the press. So what do we mean by privatisation in the NHS in 2020-2021? It's businesses making big money from the NHS. It's not yet people paying for their own treatment, either by self-pay or health insurance. This particular model of privatisation is companies making private profit from the NHS and breaking up the national service, all at increasing speed. It's remodelling on the US model. A great deal of privatisation has already happened right back to Thatcher's time, with outsourcing of cleaning leading to MRSA, privatisation of elder care and the reduction of beds in the NHS. Other people have written a lot about this. More recently, we saw PFI, outsourcing and commissioning of for-profit service providers. The 2012 Health and Social Care Act escalated this privatisation, and by 2018 to 19, NHS commissioners were spending 9.2 billion on services delivered by the private sector. The private sector has failed in the delivery of hospitals, as we saw in the Hinchinbrook scandal. But charging has started for some people. Migrants are often charged or denied healthcare. The Windrush scandal saw people who'd worked for decades in this country denied healthcare based on their migration status. And we've seen 3 women dead because they were denied maternity care when they were having a baby. This is the music of the future for all of us without a fight back. It has included a massive outsourcing of health service workers with worse pay and conditions. And we continue to fight it. We will continue to fight it. Germs and viruses kill unless we tackle them. Human life in early cities was nasty, brutish and short. Life expectancy was very short, mainly because so many babies died at birth and in infancy. There were dramatic changes that began in the 18th century with life expectancy rising. And it's risen now to 81 years in this country, although it's beginning to fall. Life expectancy in Namibia is 63 years. In the UK, it's 81 years. Dysentery, cholera, typhoid, malaria, syphilis, AIDS, SARS, Ebola, dengue fever are all still dangers to us and still have to be controlled, and further new viruses are expected. Cities can improve or damage life expectancy and quality of life, and now more than half of all humans live in urban areas, and that looks like increasing. So healthcare is essential in an urban industrial society, just like the provision of water. Not just doctors, midwives, nurses, health scientists and the linked professions, but also public health, sewers, water supply. Cities and civilizations have floundered and failed on the lack of healthcare and disease control. Poverty affects health, but you can have good healthcare in poor countries. See Cuba and Kerala, poor countries with good healthcare and good life expectancy. You can also read more details on the Guns, Germs and Steel book. There are social determinants of health. Increased poverty and decreased funding for the NHS have made a vicious circle. These are the list published by the WHO of what makes for health inequalities. And while there's a greater call on healthcare if the background living conditions are poor, Poor people end up with more health problems and more complex health problems and die earlier. So deaths at birth and in infancy and maternal deaths are all higher in poor areas. Our people have greater need for health and care because of poverty. Removing poverty reduces the call on the NHS. Increasing poverty increases the call on the NHS. Austerity and child poverty are health time bombs. We've seen major cuts to public health, and they've been worst in the areas where austerity is hit hardest. These are now the hardest hit COVID areas. NHS reorganisation and cuts mirror this and could and still could be challenged by local government. Our public health structure has been badly damaged to the point of ineffectiveness in the pandemic. What was left was ignored and underused. It's not just money cuts though, it's policies and attitudes from government. The NHS was not given to us by well-off do-gooders, but fought for by the Labour movement for decades before it was won. Mining villages organised health co-ops. Where I live in Neston, there was a version of this. Nye Bevan MP pushed the legislation through Parliament and made it reality. The speed and scope of that change should give us hope. It's the gift to us from those who defeated fascism. And Kitty Wilkinson is a very early example of people who fought for better health care and health conditions for women in Liverpool, or working class families in Liverpool. There's three models of healthcare provision internationally. There's self-pay, where if you can afford it, you pay for it. And if you don't pay for it, you don't get it. And insurance policies. And in the USA, it's combined. Self-pay is brutal. Collecting insurance and checking and limiting entitlement itself costs a lot of money. It's an expensive model to run, gives limited cover and makes lots of money for the big corporations. Then there's the social insurance model, as in Germany. There are issues of entitlement and it's quite expensive to operate. And then there's a universal health care, as in the UK. The UK health system was ranked first out of 11 developed countries for efficiency in 2013 in a widely cited study by the Commonwealth Fund. Healthcare is not an added extra, it's essential. Money well spent on healthcare makes a country richer, it's an investment. More people can work and work more productively. Fewer people have to spend time caring. Good health makes people happier and lives are saved. Now, the pillars of the NHS were that it's free at the point of need, it's a universal service available to everyone, and it was everyone, a national service so the risk is shared and the components work together. It provides the best available treatment, it's funded by the government, it's not for profit, it's a research organisation, it's linked to public health, it's the sole purchaser of the goods it needs, thereby creating price efficiencies. But we've seen death by 1,000 cuts. Cuts to funding, introducing private providers, industrial scale deceit, cuts and higher workloads for the. What we've lost already, first of all, mental health. There's a big market for private mental health hospitals, but they are funded by the NHS. It's lots of money go into it, and a lot of the money that goes into it, according to the Financial Times, goes across the Atlantic into American companies. They now run about 13% of inpatient mental health beds in England. And the imbalance is even worse amongst children and adolescents. It's not that private provision is better provision, it's worse provision. And you can see details of it in the lowdown information, which is linked here. Mind release figures showing in the previous 12 months, the NHS in England cancelled 175,000 CAMS appointments. 175,000 appointments for children with mental health issues. Hospitals became trusts in 1990 and foundation trusts were rolled out in 2004. This was all intended to make the hospitals operate more like companies, more like businesses. The system did not work, especially with the shortage of funds that they had. And in the end, the debts that were accumulated were unsustainable. But meanwhile, financial difficulties and micromanaging by the NHS national leadership had local trusts running around like headless chickens, cutting vital services. Then, in the pandemic, 13.4 billion of these debts were written off. And the scale of this is substantial, according to the government statement. 107 trusts have had 100 million revenue debts written off. We're very pleased the debts were written off, but more realistic funding systems are needed. And the other debt that needs writing off is the PFI debt. Over 100 trusts between them have another 51 billion to pay on the PFI projects. I didn't believe that number when I saw it again and went back and re-researched it. It's so big. The Liverpool Royal escaped the PFI only because the Carillion Hospital was not finished in time and still is not finished because of significant build problems. The 2012 Health and Social Care Act was probably the biggest step towards this creeping privatisation that was going on. They set up the clinical commissioning groups, ostensibly run by GPs but advised by big business. They were commissioning from private companies like Virgin and third sector like Barnardo's. And they set up healthcare scrutiny committees with the councils where they could have been held to account. The system involved breaking up the national pattern of health provision. The CCGs are set up to purchase or commission most local healthcare in your local area. A key difference between them and primary care trusts is they do not have the same obligation to treat all patients in their geographical area. They also have greater legal obligations to put services out to competitive tendering, to buy services not just from NHS hospitals but from private providers. And there was secondary legislation put through to make sure that that did happen. We've had cuts in the number of beds from 240,000 down to 166,000, and I've seen worse figures actually, but they're the ones I'm using for this. The UK has fewer doctors per head of population. The only other European countries that have lower numbers of doctors per head of population are Poland and Slovenia. According to the figures, the UK has 2.8 doctors for every 1,000 people. The average across Europe is three. The number of doctors trained is a government decision and one they got very wrong. Hospitals are being closed and services centralised. Closures have continued even during the pandemic. All of these hospitals have had big campaigns to try and save them and really raise the local population in the defence of their hospitals. A&E and maternity units have been under the greatest threat, are the most likely to have closed. Clinical outsourcing, that's not just, this privatisation is not just getting a private company to come and organise the cleaning. It's actually getting people to do the clinical work, the actual medicine of it. And diagnostics is another big involvement area for privatisation. And it's set to expand with the NHS plans for 150 community diagnostic hubs aimed at addressing the cancer backlog. They can monetize anything. There were warnings from campaigners in 2012 and 2015. The trouble is, some people fell for this integration with health and social care is a good idea, but it's broken the integration of the National Health Service. The National Health Service had integrated national clinical standards, nationally recommended treatments, national accountability, integrated funding through general taxation, integrated methods of allocating resources to areas of greatest need, or an integrated national system of pay, terms and conditions for health staff. We're facing something which is very much worse. An STP, Sustainability and Transformation Plan, or ACO, Accountable Care Organisation, or ICS, Independent Integrated Care Systems, de facto are the same things according to NHS providers. An ICS is an advanced version of an STP. And this, quote, the current direction of travel is for ICSs to submit a collective operational plan to the NHS England and NHS Improvement rather than separate organisational plans, and deliver a shared financial target across organisations within an ICS, known as the System Control Total. Our area is Merseyside and Cheshire. These ICSs are also called Integrated Care Partnerships, but they are a different model of privatisation with probably, I think, less broken up commissioning. And there's indications that that's what's happening. To understand this, you've got to understand that despite the cuts, the NHS still costs a lot of money, still involves a large stream of government funding. The NHS was one of the most industrialised world's most efficient healthcare systems, and with substantially lower costs than other advanced European countries. The Germans spend 30% more per person on healthcare than we do. And again, that's from the NHS. Planned spending for the Department of Health and Social Care in England is 140.4 billion in 2019-20. So there's a lot of money there, despite the fact there's been big cuts in real terms to funding for the NHS. And it's that stream of money which the privateers are looking for. So what's going on? The NHS is a huge successful organisation. It's a vast repository of medical research, one of the biggest employers in the world, and certainly the largest employer of skilled workers. Huge amounts of money go from the government to the NHS. It's the largest single purchaser of drugs and medical equipment, and that serves to restrict global prices. The profit seekers see it as a honeypot where they can make money, and the ideologues of profit dislike it. Step one is demand management. They're paying millions of pounds to private firms that stop patients being referred to hospital by their GPs. The full system hasn't been implemented everywhere, but there are areas within our area where your GP doesn't make the final decision about whether you are actually referred, and the BMJ is seriously concerned about the safety of this method. The pandemic, it didn't have to be this way. Find, test, track, isolate and support are the long-established fundamentals of fighting infectious diseases. It's been cut and privatised. The government's huge financial response has been used to divert resources from the NHS and public health. The money's been spent on private hospitals with no public clarity, and very many were never used, but it put a huge amount of capital into that sector. In 2016, there was a pre-planning exercise, Cygnus, for a pandemic. They knew that we went into the pandemic with too few beds, shortage of nurses, midwives and other professions, inadequate PPE and no effective test, track, trace, isolate and support system. But they decided to do nothing. But the government did take the opportunity at the start of the pandemic to cancel the trust debts to the government and introduced a system-based funding. Now, we're very pleased that the debts were cancelled, but what actually was happening was a change in the structure in the NHS. And these letters, the letter that we've linked to here, it's highlighted in a phase 3 letter published on the 31st of July 2020, telling them what will be expected, how it's going to be reorganised. And the reorganisation is under the cover of the pandemic. Whilst tens of thousands have died and many more became ill, the NHS bureaucrats have been reorganising the NHS without legal permission or public consultation. It's doubtful that even MPs understand what's happening. The integrated care systems are STPs by another name. The dangers of these integrated care systems. The propaganda is of health and social care working together to be nice and kind and fluffy and efficient, but it's far from this, though the propaganda is powerful. Social care, we remember, is not free at the point of need, nor is it comprehensive service, nor is it necessarily publicly provided. And the pressure from the NHS has been for councils to fund social care to stop bed blocking, pulling money away from children's services and disabled adults. It's simply an ineffective, damaging system. Social care is in crisis. It's not adequately acknowledged in any of these integration plans. Adult services have been cut to the bone. Funding for disabled people has been slashed. Elder care is privatised and in its own crisis. Children's services are so bad, the Children's Commissioner described children being left in the care of criminals and in bad housing conditions whilst in the care of the local authority. What's system level funding? System level funding means that all the funding for hospitals, primary care, everything comes from one regional area, the STP area. And it's likely to result in significant changes being pushed through behind the scenes due to a new funding arrangement and the pressures to increase spending on private sector management consultants, data and digital providers. Now, if you want to look out and see the extent of privatisation, look at the NHS jobs boards and see how many are not being paid on NHS funds, on NHS scales. We found one where there was a doctor's receptionist being paid on minimum wage. The new funding system, which will run to the end of the financial year, allocates its funds at a system level and requires providers and clinical commissioning groups to achieve financial balance within their ICS STP envelope. However, individual organisations within each system may record a deficit dependent on mutual agreement within their systems. So any deficits in Liverpool will have to be agreed with the whole of Cheshire. There is no democratic oversight of this situation. But it also affects the workforce. The HSSF is around 80 firms, around 24 of which are US based, and follows on from the management consultancy framework contract put into place by NHS Shared Business Services. It involved 107 companies. The framework selected companies that were pre-approved for work on 10 different lots. Consultancy UK reported, as well as reducing costs, these frameworks can streamline and harmonise the hiring processes across NHS bodies, as lengthy tender processes are reduced by having a list of preferred suppliers in place. And across the full spectrum of operations, covering everything from audit, services and construction consultancy to catering, facilities and management consultancy. Slimming down who can actually apply to do this NHS work is happening because it's more efficient, more cost efficient. It's not democratic. It's just a change because of the chaos that's there. These are the 9 areas that had their own CCGs in Merseyside and Cheshire. The Cheshire ones have all combined to have one big CCG. Hasn't been in statutory rules saying you can do it, but it's happened. And there's still arguments about what's happening with the Merseyside and Cheshire one. But meanwhile, all the finances are happening at this level, this combined level of the whole of Merseyside and Cheshire. Social care is itself in crisis. It's privately owned. It has financial problems, mainly not caused by lack of funding, but by their own mismanagement. The sector is now the subject of multiple proposals. While most concentrate on finding a solution to funding long-term care, there's been some major suggestions around service structure and delivery. The most notable of these is that responsibility of social care should be transferred from local government to the NHS. We think this is a deeply flawed proposal. Laws changed during the pandemic, so adults and children lost care, lost key provisions. Social care is failing, but as well as proper funding, it desperately needs a new vision. And it's not going to be found in the melee of privatisation of the NHS. We want to put forward the idea of disaster capitalism. We didn't invent it. Naomi Klein wrote about it, I think, first. And it's the idea of people using an opportunity, a disaster, to make money. And Fiona Lemons from Liverpool CCG said, I would expect that COVID has enabled NHS England to introduce certain things they've been thinking about and talking about in the background for quite some time. It's enabled them to do it at pace. And this section gives us the fact that, yes, these big decisions are being made at the merged CCG, the STP level. Already, now, no statutory provision for that, but that's what's happening. The people at the top of the NHS and the political parties are linked to the US companies and the private sector. This blog from Alex Scott Samuel gives a lot of detail on the issue, but I'll try and include other links to other people who've done research on that. To put crudely, the aims of the privateers are to maximise money going from the NHS budget to private profit, to disguise this process using skilled propaganda, to reduce demand on the NHS, especially demand on hospitals, and that involves rationing care, to reshape the whole service to fit their model, to build demand for treatment the NHS no longer provides, so it can go to the private sector, to provide the capital for the private sector healthcare from government funding so the private sector can grow. Note, they don't invest themselves. And to limit health workers' salaries. I want to look for a minute at the role of the NHS as the largest purchaser of drugs in the world that helps keep prices down. The US-owned global companies charge ridiculous prices for drugs, especially in the USA. But the sheer size of the NHS helps them bargain with drug companies. And other countries use the NHS prices that have been agreed to keep their prices down as well. The picture is of a demonstration against the EpiPen scandal, where the company which can make the drug for $1 for the dose has started selling it at $609. That's one example, and many people simply can't have it. And we know that in America, people go without prescriptions they badly need to survive. Even here, people who have to pay for prescriptions and are on minimum kind of wages, but not entitled to benefits, are themselves going without things like inhalers. And we know of at least one death from that. The STP ICS is another step, a deeper kind of privatisation. It's different from the 2012 model. It's using still more consultants, not the medical kind. And there was internal rows in the NHS about it. Within the NHS management, the doctors and nurses don't know unless they follow it separately, don't know what's going on. There's instructions to complete the model by April. They're taking the bakery, not just the cakes. This model matches the US model much more closely. Trade deals, here we come. All of this while the NHS should have been concentrating on the virus. Some people say to you, and within the Labour Party, it's a good idea, but it's not. It seems like common sense, but you have to do some investigation into it. The ACO, SDP, ICS areas are modelled on the US healthcare system. In the US, the insurance companies and the limited government funding sources agree on how much money each area will get for healthcare and how it will be divided up and spent. This gives a capped amount of money which will pay for healthcare and profit. The less spent on healthcare, the more on profit. Some services or treatment will not be provided on the budget, so better off patients self-pay for some of their treatments. The treatments are not available to the others. Rationing care and self-pay are already underway in the NHS. There are threats to the NHS from trade deals, from loss of advantage of scale as provider, researcher and purchaser, loss of comprehensive care, loss of the best available treatment. There'll be postcode lotteries in an already unequal service. The question, what's care, what's healthcare, is already a problem. No public accountability, limited though that is now. There's none there at the moment. There's none there in the new model. There'll be threats to life, threat to the quality of healthcare, and growing self-pay. They're a threat to local democracy and already damaged local authority budgets. They're a threat to women's health, to disabled people's involvement, to already badly damaged children's care, threats to how much money reach patient care, and there's no basis in law for what they're doing. Threats to national pay, threats to national qualifications, differences between professional in-service education and the NHS, which is good, and in social care, which is minimal. The same budget will have to provide profits, so services will be cut. Still worse response to this than future pandemics. Still less involvement of disabled people in planning their own lives, less responsiveness to public need, and ration services will fuel the demand for private hospitals. And we had this in summer 2019, this rationing of care, My Choice from Warrington Hospital. It's linked to self-pay. They advertised that you could have these services, which were considered not clinically necessary, but you could have them if you were prepared to pay for them within the NHS, not even going outside the NHS. You could pay for them within the NHS. The uproar that we roused was enough to have it paused, but it's still there. Maternity is also affected. Merseyside and Cheshire is a vanguard for national maternity care. They supported private providers, the one-to-one who went bust, leaving expectant mums in the lurch. They promote the continuity of care model without addressing staffing issues. And the UK maternity care needs vast improvements, should be the subject of a whole other meeting. So what's the council in Cheshire West doing about it? They talk about Cheshire West Integrated Care Partnership as though it's the same thing as the Cheshire and Merseyside Healthcare Partnership. Please have a look and see the difference. They're different entities, but the one does pave the way for the other. There are internal arguments and contradictions within the NHS and between the privatisers. Don't look out for it making sense. Do please follow what's going on. From the Wirral Defend Our NHS, we saw the role of private advisors. They dug through the documents and they found the fact that these people, Neil McKay, Associate Partner, GE Healthcare, Finnemore, and Peter, can't even say his name, Culloch, Senior Advisor, GE Healthcare, Finnemore, they are in the system that's organising these new models locally. Labour Party conference made it very, very clear that they did not support this model. Sadly, that opposition is being diluted. Cheshire and Merseyside is huge and desperate. We need to pull all the NHS campaigners together across the county. Making money is the immediate priority for those in control. Their systems, though, can't match the efficiency of public service. Find, test, track, trace and support's the only real hope of breaking out of repeated lockdowns and other great interruptions in our life. Yet the English system on which our freedom depends is in total fiasco. The government has so far spent, this is George Monbiot, has spent 12 billion on test and trace, but as a result of catastrophic management, it might as well have flushed this money down the toilet, as tracing has failed to reach the critical threshold needed to reduce the infection rate. Last week, after a further fall, the figure stood at 60%. 12 billion is more than the entire general practice budget. The total NHS capital spending budget for the building and equipment is just 7 billion. The situation is serious. For background reading, please follow up. I put most of these, I put links in that are worth reading, but there's lots been written about it. And I've based most of what I've said, some of it on my own research, but a lot of it on research other people have done. So we need a national response from the whole labour and trade union movement. Meanwhile, it's spread the word, one person at a time if need be. So what do? We spread the word we ask questions, awkward questions, we research, we turn up at meetings, and we campaign for a return to the Bevan model of the NHS. The demonstration is from the Save Liverpool Women's Hospital campaign demonstration in 2018, I think. So thank you very much for listening. Please do follow this up. Since completing this PowerPoint, we've learned that NICE, the regulator for health, for medicines and healthcare equipment, is itself being reviewed to fit it in with the needs of the big companies. It's systemic and it's happening, but a major campaign can stop it.